X-ray mammography is presently considered the most widely used breast imaging technique for early detection. Breast cancer is and continues to be a very important threat to the health of women all over the world. Early detection increases survival rates. A screening mammogram is illustrated. It is a low radiation dose X-ray of a woman's breast. Generally, screening is performed every 2 years on women 40 years or over who show no symptoms of breast disease. Using a collimated X-ray source at one side and a film screen unit on the other side of the breast, a classic mammography system takes an image projection of the compressed breast. Following this, dual views are then acquired of the breast, one from above known as cranial caudal and one from the side known as mediolateral oblique view. The effects of X-ray scatter are decreased by an anti-scatter grid between the breast and the film screen. X-ray energy is then converted to visible light to which the film is exposed to record the image, like the example shown above. In this case, the dense tissues circled represent tumours. With mammography, the rates of false negatives and false positives is significant because mammograms at times can be difficult to read and interpret. Due to this, more information can be sourced from other imaging techniques such as magnetic resonance imaging and computer tomography, but examination and high costs limit their use in breast cancer screening. MRI is mainly used for young women in high-risk groups as an adjunctive tool for diagnosis, which will be covered shortly. X-ray mammography decreases mortality rates in women by detecting breast cancer at an early stage before any symptoms appear, that is, during screening. A mammogram is able to detect up to 90% of breast cancers and is a very effective means of early detection. This imaging method is able to detect very small cancers which can be as small as a grain of rice before any signs or visible lumps are noticed. Hence, it is a very effective detection tool. As breast cancer is recognised as the second leading cause of death for women, the Australian Government has introduced a national screening program known as Breast Screen Australia. Breast Screen offers free mammograms every 2 years for women aged 50 to 74. Women between 40 to 49 and those 70 plus are also entitled to the free screening, however are not sent invitation letters. Recent review of the program has shown decreased breast cancer mortality rates by 21 to 28%. The program, however, has led to overdiagnosis. Mammography cannot accurately distinguish between potentially fatal cancers and less harmful cancers. Let us consider something. Is there a difference between X-ray mammography for screening and diagnosis versus using other techniques such as MRI or ultrasound? Firstly, let us address that X-ray mammography is the only current method for screening for breast cancer. Although MR is more sensitive than mammography, there can be false positives with this technology, which could lead to follow-up imaging and/or biopsies, revealing benign changes in the end. The test is also expensive, costing approximately 5 to 8 times more than a mammogram, and given current healthcare expenditures, this contributes to some reluctance to have all women undergo this study. Research has, however, shown that X-ray mammography is not sufficient alone for high-risk patients and those with dense breast tissue. One study has shown that when X-ray mammography is complemented with ultrasound, there was an increase in correct identification of cancers in 9 out of 10 cases. Sensitivity was also increased from 77% for those who received mammography alone to 91% for those who received a combination of X-ray mammography and ultrasound. Another study has found that sensitivity also increased when mammography is paired with contrast-enhanced MRI. In this study, sensitivity was significantly higher for MRI and X-ray mammography compared to mammography alone. Interestingly, this study, however, demonstrated that specificity decreased when the two imaging methods were used in combination. So what can we conclude from this? Annual screening, combining MRI or ultrasound and mammography, would detect most tumours in this risk group. However, let us now consider diagnosis. Should MRI be the imaging technique of choice? Mammograms are not perfect, as patients are exposed to low doses of radiation to breast tissue. MRIs are known to be more sensitive at detecting nearly all invasive methods and majority of in situ, non-invasive cancers. MRI screening is beneficial for young women, particularly those with dense breasts or who have an increased risk of breast cancer, possessing mutations in the genes BRCA1 or BRCA2. A study in the New England Journal of Medicine last year looked at 969 women who had already been diagnosed with cancer in one breast, and found that in 3.1% of these women, MRI found cancer in the other breast and didn't show up on a mammogram. The American Cancer Society recently recommended that any women with a greater than 20 to 25% lifetime risk for breast cancer should consider undergoing screening with both mammography and breast MRI. These high-risk women typically fell into one of the three categories and include: firstly, known carriers of the BRCA1 and BRCA2 gene mutation. Secondly, women with multiple first-degree relatives with breast or ovarian cancer, or Hodgkin's lymphoma survivors who receive radiation to their chest prior to age 30 years. It is important for women to be aware that although MRI is not a perfect test, it does offer the advantage of helping to diagnose cancers often earlier than mammography. But MRI does not replace mammographic screening. It is merely a complementary imaging tool. Contrast-enhanced MRI imaging could be used as an alternative to X-ray mammography for genetically predisposed women. Although this image modality is more expensive, the cost can be justified by the height and lifetime risk of disease these predisposed women have. Let us now consider some pros and cons of X-ray mammography. The reduction in mortality rate is the main goal of mammography screening. The initial evidence of reduction in mortality rates using X-ray come from several randomized studies that were performed as far back as 30 years ago. Today, reduction in mortality rates from the random trials are estimated to range between 15 and 30%, approximately correlating to 9 lives saved per 1,000 women screened. The benefits of X-ray mammography far outweigh the risks of radiation. Based on the average glandular dose of 3 mg, the increased risk of radiation is 6 per million women examined. This roughly is equivalent to dying in an accident when travelling 724 km per hour in a moving vehicle. Another advantage of X-ray mammography is the increased possibility of successful treatment of the cancer by early detection. It is well known that early detection leads to a reduced number of mastectomies and better cosmetic results in cases of breast conservation. The rates of chemotherapy, mastectomies, and axillary dissection drop with mammography screening. According to a study by Hutton in the Journal for Breast Cancer, the psychological impact of X-rays are far less than that for MRI procedures. MRI screening procedures were found to be more distressing than X-ray mammography. The study found that the distress was more likely to persist at 6-week scans. Higher anticipator anxiety was also reported for MRI than for X-ray mammography. Coming to disadvantages in relation to this imaging method, mammography screening is associated with exposure to a small dose of radiation. Above the age of 40, this risk of radiation is very low and even much lower than the risk of dying from breast cancer. Taking into consideration the fact that mammography screening saves lives, the risks of radiation is irrelevant compared to the advantage of early detection. Mammography screening should undergo strict quality assurance, as radiation screening is done on a healthy population. Interval cancers are cancers which become palpable between 2 screening rounds, considering that a screening round may last between 22 to 26 months. Interval cancers portray a limitation of mammography screening and not a side effect. Without screening, these cancers would also have occurred. However, the screening procedure does not allow for recognition of these cancers before the onset of the disease, which is difficult to accept both for the screeners and the patients. Interval cancers include cancers which grow fast, from an undetectable size to a clinically apparent lesion during the interval. Reliability is also an issue for mammography for women under the age of 40. The X-ray technology is often less reliable as the density of the younger women's breast tissue makes it hard to detect cancers on mammograms. This can be overcome by using MRI scans.